Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
It's great to be back for another one.
Yeah, and today we are getting into something that, honestly, I think every single person listening has lost sleep over.
Oh, absolutely.
So picture this. It's 3 o'clock in the morning. A 2-year-old is wheeled into your trauma bay after a really high-speed rollover motor vehicle collision.
The worst kind of page to get.
Yeah, and the child is crying. They are completely uncooperative and just absolutely terrified. The vital signs are borderline. The mechanism is horrific, and you are staring down this massive clinical dilemma.
Because you have to clear that cervical spine.
Exactly. Do you clear their C-spine clinically, relying on an exam that honestly feels like a coin flip, and risk missing a catastrophic life-altering cord injury?
Yeah. Or do you definitively sedate them, maybe intubate them if necessary, and slide them into the MRI scanner, which subjects them to massive iatrogenic risk for an injury that, statistically speaking, probably isn't even there.
Exactly the problem. So, welcome to today's deep dive. Today we are basically tearing up the pediatric trauma playbook and rebuilding it from the ground up.
I love it. And that scenario you just described, I mean, it perfectly encapsulates the razor's edge that trauma and surgical critical care surgeons walk every single shift, you know.
Yeah, it really does.
We're constantly balancing the fear of the missed injury against the compounding risks of our own interventions.
Right. And to you, the listener, whether you're grabbing a coffee before your surgical ICU rounds or maybe debriefing after a brutal night in the trauma bay, or even managing the complex logistics of a regional trauma system, welcome to this deep dive.
We know exactly who we're talking to here.
We do. We know your baseline. We are not here to review the basics of ATLS. We are here to look at the bleeding edge data that challenges deeply entrenched surgical dogmas.
Yeah, and today's mission is highly focused.
It is. We're taking you on the chronological journey of a critically injured pediatric patient, guided by 3 recent, heavily discussed publications that, honestly, should fundamentally alter how you practice.
Right, from the point of injury all the way through diagnostics.
Exactly. We're going to start at the point of injury and regional triage, follow the patient straight through the doors of the trauma bay for hemostatic resuscitation, and finally, navigate the absolute minefield of diagnostic imaging and cervical spine clearance.
It's the complete continuum of care. And, the reason this particular deep dive is so vital is that modern surgical critical care has evolved far beyond just pure operative technique.
Oh, absolutely. It's not just about how fast you can operate anymore.
Exactly. The data we are dissecting today highlights that mastery in our field requires aggressive resource stewardship. You have to understand how to optimize system-level triage networks.
Right, and how to mitigate the severe metabolic penalties of blood product administration.
Yeah, and how to wield diagnostic imaging with absolute precision.
Yeah.
Because every single decision has a cascading effect on patient morbidity and, frankly, hospital capacity.
So true. So let's start right at the beginning of that cascade, the front line of access.
The triage phase.
Right. We are looking at a massive 4-year pediatric teletrauma pilot project. This was published in the Journal of Trauma and Acute Care Surgery by Eldridge and colleagues.
A really fascinating paper.
It is. And to frame this, we all know the ACS Committee on Trauma mandate, right? Level 1 and Level 2 pediatric trauma centers must act as regional leaders.
Right. They're expected to extend their expertise to non-pediatric centers.
Exactly. But the glaring physical barrier to that mandate is just geography. I mean, the expertise, the specialized pediatric surgeons, the intensivists, the specialized equipment, it's all locked inside a geographic silo.
Precisely. And historically, our solution to that geographic silo was brutally simple.
Move the patient.
Yeah, physically move the patient. If a community ED evaluated a child and felt out of their depth, they put that child in a helicopter or a ground rig and sent them to the hub.
Which is not a benign intervention.
Not at all. It rips the child away from their local support system. It drains the EMS resources of the referring community. And it occupies a highly coveted, highly expensive bed at the pediatric trauma center.
Right. So what the Eldridge team investigated was flipping that paradigm. Like, instead of defaulting to moving the patient to the expertise, what happens when we use modern low-latency teletrauma networks to beam the expertise directly into the rural trauma bay?
Yeah, and let's dive deep into their methodology because the operational logistics here are actually really fascinating.
Yeah, walk us through it.
So this was a retrospective cohort study running from January 2019 through May 2023. They partnered with a statewide pediatric trauma network to institute very specific algorithmic triage guidelines at local non-pediatric partnering hospitals.
Okay, so they had a clear algorithm.
Exactly. If a pediatric patient presented to one of these local centers and was, hemodynamically stable, rather than immediately initiating a transfer, the local attending could trigger a synchronous phone or high-definition video consult with the Level 1 pediatric trauma team.
And we really need to emphasize a crucial component of their methodology that honestly often gets overlooked in these telemedicine pilots.
Continuity of care.
Yes, exactly. Continuity of care. Because this wasn't just a brief, curbside consult where the pediatric surgeon looks at a scan, says the kid is fine, and hangs up.
Right. That's what everyone fears with telemedicine.
Exactly. But the protocol here mandated that if the patient was kept at the local hospital, the pediatric trauma center team conducted daily virtual rounding on that child alongside the local clinicians until discharge.
Which is huge. That mechanism provides the safety net.
Right.
It creates a shared mental model and, frankly, distributed liability, which is exactly what a community physician needs to feel comfortable holding on to a trauma patient.
Oh, for sure. And the scale they achieved over those 4 years is genuinely impressive. I mean, they started with just 2 partnering hospitals and 12 consults in 2019.
A very small pilot.
Yeah, but by 2023, they had scaled to 32 partnering hospitals, logging over 150 consults. And the geographic footprint is staggering.
Yeah, the distance data is wild.
It is. These partnering hospitals were located anywhere from 15 miles to 554 miles away from the pediatric center.
554 miles.
That's a massive distance. The median was 34 miles, but 11 of those hospitals were over 100 miles out.
Right, and when you were projecting surgical expertise across a 500-mile radius, you are crossing mountain ranges, state lines, and vast stretches of austere environments where weather frequently grounds rotoling assets anyway.
Exactly, which makes the demographic and injury profile of these teletrauma patients so compelling.
Yeah, let's talk about the patients.
So the median age was 8, interquartile range of 4 to 12, 62% male. But here's the critical data point that you, the trauma surgeon, need to pay attention to.
70% of these Teletrauma consults were for head injuries.
Yes, 70%. And that makes perfect sense, doesn't it?
It absolutely does. If you are a community emergency physician, a pediatric head injury is terrifying.
Oh, completely.
A kid comes in after a fall from a jungle gym. They have a non-displaced linear skull fracture, maybe a tiny sliver of subarachnoid blood, but their neuro exam is currently pristine. The anxiety in that room is just palpable.
Right, because the reflex, driven by the fear of a delayed epidural bleed or sudden decompensation, is to just fly the kid out.
Exactly. The local physician is visualizing the absolute worst-case scenario. But what the Eldridge data demonstrates is how effectively that teletrauma consult de-escalates that anxiety.
Yeah, because out of the 151 consults, the Pediatric Trauma Center recommended transfer only 35% of the time.
Only 35%.
Right, meaning in 64% of cases, the transfer was entirely avoided.
That is massive.
It's 97 pediatric patients who did not get strapped to a backboard and loaded into a loud, terrifying transport vehicle.
Yeah, and of those 97 kids, 54 were discharged straight home from the local ED, and 43 were admitted to the local hospital under the virtual collaborative supervision of the pediatric trauma team.
Think about the system-level implications of that outcome.
Right. That equates to 97 pediatric trauma beds, nursing shifts, and potential OR holds that were kept completely open at the Level 1 center for patients who actually required advanced intervention.
Okay, but here is where we have to push back on the premise a little bit.
Okay, hit me.
I am putting myself in the shoes of the attending pediatric trauma surgeon taking that video call at 2 a.m. I am advising a physician I may not know at a hospital I have never visited regarding a child I cannot physically lay my hands on.
Right, the tactile barrier.
Exactly. I can't palpate the abdomen. I can't perform my own neurologic exam. What happens when the video feed doesn't capture the subtle clinical nuance and we make the wrong call?
It's a valid fear.
Because if we advise keeping the kid local and they crump, the liability and the patient harm are catastrophic.
Yeah, that loss of tactile feedback is the inherent psychological barrier to telemedicine and surgery. But the safety data from this cohort is profoundly reassuring.
Okay, what does it show?
Let's look exactly at what happened to those 97 patients who were held locally. Out of that entire group, only 3%, exactly 3 patients failed local management and required a delayed subsequent transfer to the Pediatric Trauma Center.
Okay, but we need to look at the etiology of those 3 failures. Like, why did they require delayed transfer?
The study specifically breaks this down. One patient experienced a worsening traumatic brain injury characterized by a declining neurologic exam.
Okay, so an evolving bleed.
Right. One patient developed worsening abdominal pain concerning for evolving peritonitis, and the third was transferred primarily due to escalating parental concern regarding the management of a complex globe rupture.
Okay, so this is where we have to apply our clinical experience to the data. Look at those three specific clinical scenarios. A slow venous epidural or subdural bleed that takes 12 hours to manifest clinically. A hollow viscous injury or a subcapsular splenic hematoma that slowly evolves into peritonitis. And intense parental anxiety over an ocular injury.
Right. And what do all those have in common?
They are the exact same clinical evolutions that happen when the patient is sitting in a bed on your own surgical ward.
Exactly. Trauma is a dynamic disease state. The fact that a patient's condition evolved does not represent a failure of the teletrauma system.
Right.
It represents the natural history of the injury. The true metric of safety is whether the system recognized the change and acted before a catastrophic outcome occurred.
And the authors are unequivocal on that point, right? There were 0 major complications and 0 deaths among the patients who utilized the teletrauma consultation service.
0. The local physicians identify the clinical deterioration, they utilize the daily virtual rounds to escalate their concerns to the pediatric hub, and the transfers were executed safely.
The safety net held?
It held perfectly. But, to truly validate this system, the researchers knew they couldn't just look at the teletrauma cohort in a vacuum.
They needed a control group.
Exactly. They had to evaluate it against the standard of care. So they performed a really brilliant comparative analysis.
Okay, lay it out.
Over the same 4-year study period, the Pediatric Trauma Center received approximately 4,000 traditional pediatric transfers. So these are kids sent over without any prior teletrauma consultation.
Just the standard call and transport model.
Right. And the researchers defined a specific subgroup of these as avoidable transfers.
And how did they define that?
An avoidable transfer was strictly defined as a patient who was transferred to the Level 1 center, but who was subsequently discharged within 36 hours of arrival without ever requiring a specialized surgical intervention, advanced imaging, or critical care resources.
Okay, and out of those 4,000 traditional transfers, an astounding 923 patients met the criteria for an avoidable transfer. That's nearly a quarter of all patients transferred to the Pediatric Trauma Center essentially did not need to be there.
Yeah, that is the textbook definition of secondary overtriage. Now, what happens when we statistically compare the 97 teletrauma patients who were successfully kept at their local hospital against those 923 avoidable transfers?
The findings are highly significant and honestly somewhat counterintuitive.
Very counterintuitive.
Because the patients managed successfully via teletrauma actually had a significantly higher rate of traumatic brain injury compared to the avoidable transfer group.
Right, 61% versus 31%, with a highly significant p-value of less than 0.001.
Okay, I have to stop you there because that initially sounds backward.
I know, right?
You would intuitively expect that the kids with the higher incidence of head trauma would be the ones getting transferred, while the kids staying at the community hospital had, isolated extremity fractures or simple lacerations. Why is the higher acuity staying local?
Well, it all comes down to the psychology of clinical uncertainty.
How so?
When a community physician is managing an isolated femur fracture, the pathway is clear. They know how to splint it, they consult local ortho, or they transfer.
Right, it's a known entity.
But when they are faced with a pediatric head bleed, the clinical pathway is murky. If they do not have a teletrauma lifeline, that clinical uncertainty immediately translates into a transfer order.
Because they don't want to hold that risk alone.
Exactly. Those kids become part of the 923 avoidable transfers. But when that same physician can initiate a video consult, show the CT scan to a pediatric neurosurgeon, and have that specialist confirm, the basal cisterns are open, the midline is perfectly centered, this is a minor contusion, keep them in your observation unit, and I will see them with you on video tomorrow morning. That high-anxiety patient safely stays put.
So the teletrauma system directly empowers the local clinician to manage a perceived higher acuity of injury.
That's exactly it.
That makes perfect sense. And the geographic data from the study reinforces this psychological aspect of overtriage, too.
Oh, the distance data is fascinating.
Yeah, they found that the patients managed locally via teletrauma live significantly farther away, a median of 40 miles compared to 30 miles for the avoidable transfer group, again with a p-value of less than 0.0001. wide. And more tellingly, they noted that hospitals situated closer to the pediatric trauma center were actually much more likely to bypass the teletrauma system entirely.
Yeah, 63% of transfers coming from within a 100-mile radius skipped the consult and just sent the patient.
Whereas only 23% of transfers originating from beyond 100 miles skipped the consult.
This is a masterclass in human behavior within healthcare systems.
It really is.
The activation energy required to execute a transfer dictates the behavior. If your community hospital is only a 30-minute ground transport away from the Level 1 hub, it is logistically easier for the attending to simply sign the transfer paperwork and put the child in the ambulance than it is to log into the teletrauma portal, wait for the consult, and take on the burden of ongoing local management.
Right, it's the path of least resistance.
Exactly. But if your hospital is 250 miles away and transferring that child requires mobilizing a fixed-wing aircraft or a helicopter team, coordinating flight weather checks, and displacing a parent who now has to drive 4 hours alone in the middle of the night.
The local team is highly motivated to use the teletrauma system to avoid that logistical nightmare.
100%.
Which perfectly segues into the financial implications of this study. The authors performed a rigorous cost analysis and estimated that avoiding those 97 transfers saved approximately $4.3 million.
And when you drill down into that number, $3.1 million of those savings were derived entirely from transportation costs.
Because we all know the exorbitant cost of aeromedical transport. You are paying for the fuel, the specialized flight crew, the maintenance of the airframe, and the sheer overhead of running a 247 rotor wing program.
Yeah. And remember, that $4.3 million only accounts for the direct healthcare and transport expenditures. It completely ignores the indirect, massive societal costs. It doesn't capture the lost wages of the parents who have to take unpaid leave to stay in a distant city. It doesn't account for the hotel rooms, the gas, the meals.
Right. For a rural or socioeconomically disadvantaged family, an unnecessary helicopter transfer for a minor concussion can trigger a cascade of financial toxicity that lasts for years.
Absolutely.
So let's contextualize the Eldridge data within the broader trauma literature because they're building on a pretty significant foundation here.
Yeah, they didn't just invent this concept in a vacuum.
Right. The paper heavily references Perea et al.'s work evaluating secondary overtriage in Pennsylvania, Taylor et al.'s earlier proof of concept regarding rural state telemedicine, and Vogel et al.'s historical data from 2001 to 2009 looking at pediatric transfer variations in Northern California.
Yeah.
So how does this new 2024 study move the needle?
Well, the foundational problem of secondary overtriage is really well documented. Perea's work in Pennsylvania definitively proved that we are moving far too many kids who don't need to be moved. And we've known from Keen's systematic reviews that mild pediatric TBI is highly amenable to non-pediatric center management. What makes the Eldridge study a paradigm shift is the sheer scale and the modernization of the methodology.
Right, because Vogel's Northern California data was gathered before the proliferation of ubiquitous, high-definition, low-latency, mobile video technology.
Exactly. And Taylor's rural study was fantastic, but it was highly localized to specific, well-resourced pilot sites. What Eldridge and their team proved is that this is highly scalable.
They stretched this across 5 states and 32 disparate hospital systems.
Right. They demonstrated that if you combine standardized algorithmic triage with the technological capability of video consults, and you back it up with the rigorous quality assurance of daily virtual rounding,
you can fundamentally alter regional triage patterns on a massive scale.
you really can.
So bringing this back to you, the listener, if you are a trauma medical director or you sit on a regional trauma advisory committee, you need to look hard at your own institutional data.
Absolutely. Pull your secondary over-triage rates.
Yeah. If you find that 20%, 25%, or 30% of your pediatric transfers are being discharged from your trauma bay or your floor within 24 to 36 hours without an intervention, you are burning resources.
You have a prime, evidence-based mandate right here to build a teletrauma network. It protects your ORs, it protects your staff from burnout, and most importantly, it keeps kids in their own communities.
Exactly. Start simple. You don't need $1 million proprietary telemedicine cart in every rural ER.
No, start by distributing a clear, concise, one-page algorithm detailing exactly which injuries mandate immediate physical transfer and which injuries mandate a phone call to the attending trauma surgeon.
That single intervention will intercept a massive portion of your secondary overtriage.
Without a doubt.
But, inevitably, the teletrauma system will identify a patient who genuinely requires your expertise.
Right, the system works, they find the sick kid.
Exactly. The local ED makes the call. The video feed shows a child who is hypotensive, tachycardic, and pale. The consult confirms this child needs immediate operative intervention.
You need to fly.
Right. 2 hours later, the rotors spin down on your helipad. The doors swing open, and you are receiving a pediatric patient in profound, decompensated hemorrhagic shock.
The worst case scenario.
Historically, we have managed this by reaching for balanced component therapy, but the data from the University of Arizona suggests we have been doing this entirely wrong.
Yeah, this is one of the most aggressive, rapid paradigm shifts we have seen in modern trauma resuscitation.
Yeah.
We are talking about the transition from component therapy to whole blood.
It's a huge shift. To understand why this shift is happening, we have to look at the translational history.
Right.
Over the last decade, driven largely by military data from conflicts in Iraq and Afghanistan, and subsequently validated in massive civilian trauma systems, the adult trauma community has decisively embraced low-titer Group O whole blood for hemostatic resuscitation.
It's basically the standard of care now for adults.
But pediatric trauma surgeons have been hesitant to adopt it, largely due to concerns over volume overload, antibody titers, and a lack of robust pediatric-specific data.
And that hesitation is understandable, honestly. But to understand why whole blood is so physiologically superior, we have to critically examine what we've been using for the last 20 years.
Component therapy.
Right. Component therapy. When a donor gives a unit of blood, the blood bank traditionally centrifuges it and fractionates it into 3 distinct products: backed red blood cells, fresh frozen plasma, and platelets.
Because the logistical argument was that one donated unit could serve 3 different patients with distinct needs, right?
Exactly. An anemic patient gets the PRBCs, a coagulopathic patient gets the plasma, and a thrombocytopenic patient gets the platelets. It makes sense for a blood bank.
But a trauma patient who has just severed their femoral artery isn't bleeding just PRBCs or just plasma.
No, they are bleeding whole functional blood.
So our historical solution was to try and rebuild whole blood in the trauma bay. We instituted massive transfusion protocols that delivered PRBCs, plasma, and platelets in a strict 1.1.1 ratio. I have to play devil's advocate here, though. If I am giving 1.1.1 component therapy, I am giving the patient red cells, I am giving them coagulation factors, and I am giving them platelets.
You're giving them all the pieces.
Right. I am giving them all the pieces of the puzzle. Why does it matter if those pieces come 3 separate plastic bags instead of 1? Are we just arguing over packaging logistics?
It is so much more than packaging. It is a profound physiological penalty.
Walk me through it.
The 1.1.1 component therapy strategy is essentially a deeply flawed attempt at alchemy.
Oh.
Think of whole blood like a perfectly mixed, highly structural concrete.
Okay, I like that analogy.
When you fractionate it into component therapy, you're essentially trying to rebuild a shattered concrete foundation by pouring the water, the cement powder, and the gravel into the trench at different times, hoping it mixes perfectly while the foundation is actively washing away.
Yeah, that doesn't sound like it's going to hold.
It doesn't work. When you administer a reconstituted 1.1.1 mix of components, you are not delivering whole blood, because each of those individual bags requires its own volume of preservative and anticoagulant fluid to remain viable in storage.
Ah, so the final reconstituted mixture is inherently dilute.
Exactly. A 1.1.1 massive transfusion yields a hematocrit of roughly 29%, a platelet count hovering around 80,000, and severely diluted coagulation factors.
You are inducing dilutional coagulopathy from the very first drop.
Precisely. You are infusing a coagulopathic fluid into a patient who is already suffering from trauma-induced coagulopathy.
That's wild when you think about it.
But the physiological insult gets worse when you look at the metabolic toll.
The citrate.
The citrate. Every single bag of component therapy is loaded with citrate to prevent it from clotting in the blood bank. And how does citrate work?
It aggressively binds ionized calcium.
Exactly. When you rapidly infuse massive volumes of component therapy, meaning 3 bags for every equivalent unit of whole blood, you are delivering a massive toxic load of citrate directly into the patient's central circulation.
And that citrate binds the patient's endogenous ionized calcium, completely plummeting their calcium levels.
And we know calcium is factor 4 in the coagulation cascade. Without ionized calcium, the cascade completely arrests. No fibrin is formed, the clot fails, and the patient bleeds harder.
Right. Furthermore, ionized calcium is essential for myocardial contractility and vascular smooth muscle tone.
Right, so you lose your squeeze.
Exactly. So the citrate toxicity directly causes myocardial depression and vasoplegia, compounding the hemorrhagic shock they're already in.
It's a vicious cycle. And the final penalty of component therapy is donor exposure.
Ooh, this is a big one.
If a pediatric patient requires a massive transfusion equivalent to 10 units of whole blood, and you use 1.1.1 component therapy, that child is exposed to the antigens and inflammatory mediators of 30 different distinct donors.
30 different immune systems hitting this kid at once.
Right. That massive immunologic hit dramatically increases the risk of alloimmunization, transfusion-related acute lung injury, or Toll-Rayleigh, and systemic inflammatory response syndrome.
Whereas whole blood is, well, exactly what it sounds like.
Exactly. It is collected from a single donor, kept cold, and stored whole. It has a significantly higher hematocrit, a higher concentration of functional platelets, vastly less anticoagulant volume, requires only one line to rapidly infuse, and exposes the patient to a fraction of the donors.
The physiological argument is bulletproof. I mean, it just makes sense. But we need hard clinical data to prove it translates to pediatric patients.
Need the numbers.
Right, and that brings us to the landmark study by Anand and colleagues, published in the Journal of Trauma and Acute Care Surgery in 2021.
A fantastic paper.
They utilized the massive Trauma Quality Improvement Program, or TQIP, database from 2017 to perform a nationwide retrospective analysis. They specifically isolated pediatric patients aged 1 to 17 years old who were severely injured and required blood product transfusion within the first 4 hours of arrival.
And because this is a retrospective database study, we really must scrutinize their statistical methodology.
Yeah, we have to talk about propensity matching.
Because if you want to compare the efficacy of whole blood versus component therapy, the gold standard would be a randomized controlled trial.
But randomizing a hemorrhaging dying child to receive a potentially inferior resuscitation product is ethically perilous and logistically nightmarish.
Yeah, no IRB is approving that easily. So researchers rely on massive registries like TQIP. However, registry data is plagued by selection bias.
Because in the real world, the trauma attending might reserve their precious supply of whole blood for only the most critically moribund patients, while using component therapy on the more stable ones.
Exactly. If you just run a raw comparison, the whole blood group will inevitably show a higher mortality rate, not because the blood is dangerous, but because it was given to patients who are already dying.
Which is why the Anand team utilized propensity score matching. They essentially forced the data to mimic a randomized controlled trial.
Right. Through complex logistic regression, the statisticians calculate a propensity score for every single patient. This score represents the mathematical probability that a specific patient would receive whole blood based entirely on their baseline characteristics prior to any intervention.
It levels the playing field.
Exactly. They took the patients who received whole blood, supplemented with component therapy, the WBCT group, and meticulously matched them to patients who received only component therapy.
And they matched them on a very granular level, right? Age, gender, exact mechanism of injury, presenting vital signs, GCS, the presence of specific hemorrhage control interventions like Reboe or massive laparotomy, and even the verification level of the trauma center.
They did. They matched 135 patients in the WBCT group to 270 patients in the component therapy only group, establishing a strict 1.2 ratio.
So by doing this, they effectively neutralized the confounding variables. They created two cohorts that were mathematically and clinically identical in severity.
And the acuity of these matched cohorts was extreme. The median injury severity score, the ISS, was 32.
Which is huge. To put that in context, an ISS over 15 is universally classified as major multi-system trauma.
Yeah, an ISS of 32 means you are barely hanging on. 51% of these children presented in profound clinical shock. 34% suffered penetrating trauma, gunshot wounds, and stabbings. And over 40% required immediate surgical intervention to control the hemorrhage.
These were the sickest of the sick. Now let's look at what happened when they analyzed the primary outcome. The total volume of blood products required to achieve hemostasis.
This is where the physiological argument is validated by the data.
At the 4-hour mark, the WBCT group required significantly less total volume. A median of 35 millikilograms compared to 48 millikg for the component therapy group, with a p-value of 0.013.
And as the resuscitation continued, that gap widened dramatically. By 24 hours, the whole blood group had received 39 millikilograms, while the component therapy group required 53 millikg, yielding a highly significant p-value of less than 0.001.
That volume differential is massive in a pediatric patient.
It's massive, and it's because whole blood delivers a concentrated, balanced, highly functional hemostatic payload without inducing the dilutional coagulopathy or citrate toxicity we discussed.
Right. The patient actually forms a stable clot faster, the surgical field dries up sooner, you turn off the faucet earlier, so you need less total volume.
Exactly, and that reduction in volume profoundly impacts the rate of massive transfusion. In pediatric trauma, the threshold for a massive transfusion protocol is generally defined as receiving more than 40 millikilogram of blood products within 24 hours.
What did the study find there?
It found that an alarming 67.8% of the children resuscitated with component therapy crossed that dangerous massive transfusion threshold.
Wow.
Yeah. In stark contrast, only 48.9% of the children who received whole blood crossed it. Again, a highly statistically significant difference with a p-value less than 0.001.
And crossing that 40 millimilligauss threshold is not just an arbitrary metric, it is a critical clinical inflection point.
Oh, absolutely.
When a child crosses that line, they are spiraling into the lethal triad of coagulopathy, acidosis, and hypothermia. They are at massive risk for volume overload, leading to hydrostatic pulmonary edema, acute respiratory distress syndrome, and abdominal compartment syndrome.
Keeping the patient below that threshold is absolutely paramount.
And we clearly see the downstream clinical benefits of avoiding that volume overload when we look at the secondary outcomes.
Yeah, the ventilator days.
Right. The UNNON study found that the patients in the whole blood group required significantly fewer days on mechanical ventilation, a median of 2 ventilator days versus 3 days for the component therapy group, with a p-value of 0.021.
Because when you pump a child full of dilute, highly inflammatory component therapy, their lungs fill with fluid, their compliance drops, and they languish on the vent.
Whole blood keeps the lungs dry and facilitates faster extubation.
It does. But as with all complex data, we have to address the caveat.
The mortality data.
Right. The ultimate metric we chase in trauma resuscitation is survival. Yet despite the massive reduction in transfusion volume and ventilator days, the UNNON study found absolutely no statistically significant difference in 24-hour mortality or overall in-hospital mortality between the two groups.
Mortality hovered around 31% to 34% for both cohorts.
Yeah, and there was also no difference in the overall hospital length of stay.
This is the finding that skeptics will immediately point to, and we need to unpack it by comparing it to the existing literature.
Because if we review the foundational adult studies, like Avery Laws's pivotal work comparing whole blood to component therapy, or the comprehensive meta-analysis conducted by Mezzoso and the Eastern Association for the Surgery of Trauma, the East Practice Management Guidelines,
those adult populations frequently demonstrate a distinct, undeniable mortality benefit associated with whole blood.
Exactly. So why does that mortality benefit vanish in the pediatric TQIP data?
Is it an artifact of the database itself? We know TQIP suffers from inherent survivor bias. A child who sustains a massive aortic disruption and bleeds out in the trauma bay within 10 minutes never receives blood, or they die before the data can be accurately coded into the registry.
Right. We are only analyzing the kids who survives long enough to actually get resuscitated.
Exactly. Survivor bias is absolutely a limitation of all registry data.
It is entirely possible that this specific MASH cohort of roughly 400 patients was statistically underpowered to detect a difference in mortality, which, despite the high ISS, remains a relatively rare event compared to the ubiquitous need for transfusion volume.
True, but there is a much more profound physiological explanation, and it highlights the variance in demographics.
The age factor.
Right. The median age in this pediatric cohort was 12. Pediatric physiology is vastly, fundamentally different from the 65-year-old adult trauma patient who presents with underlying hypertension, coronary artery disease, and limited cardiovascular reserve.
Oh, a healthy 12-year-old possesses an immense, almost terrifying physiological reserve.
Right. They can maximally clamp down their peripheral vasculature, increase their heart rate to 180 beats per minute, and maintain a completely normal systolic blood pressure despite losing 30% or 40% of their circulating blood volume.
They will compensate right up until the moment they abruptly code.
Exactly. Because of that incredible resilience, pediatric trauma patients do not succumb to the immediate hemorrhagic insult as rapidly or as easily as adults do. A child can often survive the initial period of hemorrhagic shock, regardless of whether you resuscitate them with the superior whole blood or the inferior component therapy.
Their bodies will just take the punishment. Therefore, in the pediatric demographic, the primary benefit of whole blood shifts from a mortality benefit to a morbidity benefit.
That is the critical distinction.
You might not necessarily save a higher absolute number of lives because the kids are resilient enough to survive the component therapy. But the lives you do save will have dramatically less morbidity.
They will suffer less volume overload. They will spend fewer days paralyzed on a ventilator. They will avoid the profound inflammatory insult of multiple donor exposures. And they will suffer less severe dilutional coagulopathy.
And in the realm of pediatric critical care, minimizing that prolonged intensive care morbidity is an incredibly valuable, highly relevant victory.
Which brings us to the operational reality for you, the listener. Say you want to implement this. You look at the NN data, you see the reduction in volume and vent days, and you want to start stocking low-titer O-positive or O-negative whole blood for pediatric trauma.
It's a tough sell sometimes.
Right. How do you actually get this past a skeptical blood bank director who is terrified of the logistics? They're going to point to this study, note the lack of a mortality difference, and ask why they should upend their entire supply chain just to save a day on the vent.
You have to speak their language. You don't walk into the blood bank and argue mortality. You argue resource utilization and product conservation.
Good point.
Blood banks nationwide are facing critical, unprecedented shortages of fractionated products. You present the ANAN data showing that the whole blood group required significantly fewer total blood products at 4 hours and 24 hours.
You are mathematically proving that by using whole blood, you are actually utilizing less of the overall community donor pool to achieve hemostasis. You are conserving resources.
Exactly. And then you bring your pediatric intensive care director into that meeting to advocate for the downstream effects.
Right, because every single day a pediatric trauma patient remains intubated, costs the hospital thousands of dollars, occupies a critical ICU bed, and exponentially increases the risk of ventilator-associated pneumonia and neuromuscular weakness.
You pitch HUNLUD not just as a resuscitation fluid, but as a hospital-wide quality improvement initiative designed to drastically reduce ICU length of stay and mitigate the lethal triad before the patient ever leaves the OR.
It requires a massive multidisciplinary effort. You have to navigate the politics of titering, deciding your institutional threshold for anti-A and anti-B antibodies to define low titer.
You have to figure out the cold storage logistics in the trauma bay.
But the physiological rationale, backed by this robust propensity-matched data, makes it unequivocally clear that whole blood is the superior hemostatic agent for the severely injured child.
So we continue our journey.
Let's do it.
Your patient has survived the Teletrauma triage network. They have survived the trauma bay, having been expertly resuscitated with low-titer whole blood. The massive hemorrhage is controlled, the coagulopathy is reversed, the child is stabilized, extubated, and is now moving toward the definitive diagnostic workup.
And here is where we encounter what is arguably the most anxiety-inducing, frustrating, and legally terrifying scenario in all of pediatric trauma.
Clearing the toddler's cervical spine.
Right. If you poll any group of experienced trauma surgeons or pediatric emergency physicians and ask what clinical scenario keeps them up at night, clearing a 2-year-old C-spine will universally be in the top 3.
The clinical dilemma is paralyzing because you are trapped between two extremes.
Exactly. On one side of the equation, pediatric cervical spine injury, or CSI, is exceedingly rare. Historically, the prevalence in blunt trauma is cited anywhere from 0.7% to maybe 2%. It is a needle in a haystack.
But on the other side of the equation, the consequences of missing that needle are catastrophic. We are not talking about a missed distal radius fracture that heals a little crooked.
We are talking about missing an unstable ligamentous injury that subsequently subluxates, resulting in a high-level spinal cord transection. We are talking about lifelong quadriplegia, permanent ventilator dependence, or death. The stakes literally could not be higher.
And the frustration stems from the fact that we cannot utilize the robust, validated tools we use every day for adults.
Right. If a 25-year-old comes into the trauma bay after a motor vehicle collision, we simply apply the NXUS criteria, or the Canadian C-spine rule. We assess for midline bony tenderness, we look for distracting injuries, we ensure they aren't intoxicated, and we verify there are no focal neurologic deficit.
If they meet the criteria, we take off the rigid collar, and the spine is cleared without ever radiating the patient.
But you cannot apply NXUS to a 2-year-old.
Because a 2-year-old is inherently and unavoidably uncooperative. They lack the developmental capacity to reliably localize pain. They can't tell you if their neck hurts or if they have numbness in their fingers.
Furthermore, every single injury is a distracting injury when you are 2 years old and terrified in a bright room full of strangers.
Exactly. And the challenge is compounded by the unique biomechanics and anatomy of the pediatric cervical spine.
A toddler's head is massive relative to their body weight, creating a pronounced fulcrum effect centered high up in the cervical spine, typically around C2, C3.
Their vertebral facet joints are oriented much more horizontally than the vertical orientation seen in adults, allowing for excessive translation.
And crucially, their spinal ligaments and joint capsules are incredibly elastic and hypermobile.
Which leads to the terrifying phenomenon of Siwara.
Spinal cord injury without radiographic abnormality.
Siwara is the boogeyman of pediatric trauma. Because of that immense ligamentous elasticity, during a high kinetic event like a car crash, the child's vertebral column can stretch and briefly, violently subluxate or distract.
The bones pull apart.
Right. But because the ligaments are elastic, the bony column immediately snaps back into normal anatomical alignment. So when you take a plain X-ray or even a high-resolution CT scan of the bone, the alignment looks absolutely perfect.
But the spinal cord itself, nestled inside that canal, is not elastic. During that brief moment of bony distraction, the cord is stretched, contused, or partially transepted.
The bones are fine, but the cord is devastated. And the only imaging modality that can definitively visualize that ligamentous disruption, that intramedullary edema, or the spinal cord contusion, is magnetic resonance imaging.
But getting an MRI on a 2-year-old is a massive undertaking.
It's huge.
It requires transporting a potentially unstable patient out of the critical care environment, deep sedation, or frequently full general anesthesia with intubation, just to get them to hold still in the tube for 45 minutes. That carries significant inherent risk.
So we are trapped. We fear missing the catastrophic Siwara, but we know the profound risks of overimaging. We don't want to needlessly irradiate a child's thyroid with a CT scan, and we don't want to needlessly anesthetize them for an MRI.
Right. To solve this exact dilemma, back in 2009, researchers developed a clinical prediction rule called the PEDSPINE score.
They analyzed a large cohort of children under 3 years old and developed a simple, highly elegant score ranging from 0 to 8 points based on 4 distinct clinical risk factors.
If the child had a Glasgow Coma Scale score of less than 14, they got 3 points. If their GCS-I component was a 1, meaning no eye opening to pain, they got 2 points. If the mechanism was a motor vehicle collision, that was 2 points. And if they were older than 2 years of age, that was 1 point.
And the true brilliance of that original 2009 PEDSPINE score was its negative predictive value.
Right.
The data showed that for any toddler who scored less than 2 points, the negative predictive value for a cervical spine injury was an astounding 99.3%.
It provided trauma surgeons with a robust, data-driven shield. You could look at a crying, scared 1-year-old who fell off a couch, calculate a score of 0, and confidently tell the parents, the statistical risk of a spine injury is microscopically low. We do not need to irradiate your child, and we do not need to put them to sleep for an MRI.
It was the ultimate diagnostic stewardship tool.
But medicine is not static. Technology evolves, and practice patterns shift. And that brings us to the highly anticipated source data for this segment, the PEDSPINE II study, orchestrated by Luckhurst and a massive multi-institutional consortium published in JAMA Surgery in 2023.
The authors astutely recognized that the original PEDSPINE cohort was essentially compiled in a different era of medicine.
Over the last 15 years, the landscape of trauma imaging has drastically, fundamentally changed. We are scanning far more frequently. The resolution of our multi-detector CT scanners has vastly improved.
And most importantly, the utilization of advanced high-field MRI-like 3 Tesla magnets has become ubiquitous in pediatric trauma workups. The researchers set out to rigorously reevaluate the original score against a modern cohort and determine if a new, more advanced prediction model was necessary.
The scale of the PEDSPINE II study is monumental. This is not a single-center retrospective chart review. They aggregated data across 15 different trauma centers, encompassing both standalone, dedicated pediatric hospitals and pediatric centers embedded within larger adult trauma systems.
They evaluated over 10,000 pediatric patients younger than 3 years of age who presented following blunt trauma over a 10.5-year period. After exclusions, a massive cohort of 9,389 patients was included in the final analysis. The mean age of the cohort was just 1.3 years.
This is an incredibly robust, highly representative sample of modern pediatric trauma. And when they analyzed the data, the findings regarding the epidemiology of cervical spine injury were absolutely shocking.
What did they find?
In the original 2009 PEDSPINE study, the documented rate of cervical spine injury in this age group was a mere 0.66%. In this modern PEDSPINE II cohort, that rate had literally doubled to 1.36%. Out of the 9,389 toddlers, 128 were diagnosed with a confirmed CSI.
And running concurrently with that doubled injury rate, the imaging rate skyrocketed. In the original historical study, about 63% of these toddlers received some form of cervical spine imaging. In PEDSPINE II, a staggering 80% of these young children were subjected to advanced imaging.
Which forces us to ask the ultimate epidemiological question.
Right. Are we suddenly seeing a massive spike in the severity of pediatric trauma? Are car seats failing? Are modern vehicles transferring more kinetic energy to the child?
Or is this purely an artifact of our own diagnostic aggressiveness? Are we just throwing every single toddler in the high-resolution 3T MRI scanner and finding tiny, clinically insignificant injuries that we used to blissfully ignore because our old technology couldn't see them?
It is almost certainly the latter. This is a classic demonstration of verification bias, also known as overdiagnosis.
Explain that for us.
Whenever you introduce a highly sensitive diagnostic modality into widespread practice, the apparent incidence of the disease artificially rises. We have seen this with pulmonary embolisms and high-resolution CT angiograms.
Right, we're finding things that maybe don't matter clinically.
Exactly. In the context of the pediatric spine, modern 3 Tesla MRIs are incredibly sensitive. They detect microscopic ligamentous sprains, tiny areas of intramedullary edema, or minuscule hematomas in the paraspinal musculature that may have absolutely zero impact on the mechanical stability of the spine or the child's long-term neurologic function.
But because the radiologist sees the bright spot on the T2-weighted sequence, it gets officially coded in the registry as a cervical spine injury.
And this shifting prevalence, this doubling of the disease rate due to overdiagnosis, completely destabilized the original PD spine score.
It did. The researchers took the modern cohort and mathematically applied the original 2009 scoring system to see how it performed. They found that the area under the curve, the AUC, dropped significantly from an excellent 0.92 in the original study down to a mediocre 0.81 in the modern cohort.
We need to pause and really explain the area under the curve, because understanding it is vital for any physician relying on clinical prediction rules.
So go for it.
The AUC is a metric derived from a receiver operating characteristic, or ROC curve. It measures a model's overarching ability to correctly discriminate between a patient who actually has the disease and a patient who does not. An AUC of 1.0 represents a flawless, perfect test. An AUC 0.5 is functionally useless. It is no better than flipping a coin.
So an AUC of 0.92, which the original score had, is outstanding. It means the tool is highly reliable. But a drop to 0.81 is a massive degradation in predictive power.
It is a dangerous drop. An AUC of 0.81 at 2 a.m. means your trusted safety net suddenly has massive holes in it. It indicates that the old score was actively misclassifying patients in this modern cohort. It was failing to identify injuries, largely because the types of injuries being diagnosed had shifted.
Because we're picking up different things now.
Yes, the old score was excellent at predicting the gross mechanically unstable fracture seen on x-rays in 2009. It was utterly failing to predict the subtle MRI-diagnosed ligamentous edemas that dominate the modern registry.
The Luckhurst team realized they couldn't just arbitrarily tweak the points of the old score. They needed a fundamental, foundational, methodological shift in how we predict these injuries.
And this is where the statistical architecture of PEDSPINE II becomes incredibly elegant. They abandoned the traditional binary approach. They didn't just build a model that predicts injury versus no injury.
Instead, they utilized a complex, multinomial logistic regression model designed to classify the patient's outcome into 3 distinct, mutually exclusive categories.
Right. Category 1, no injury. Category 2, osseous injury, meaning fractures, bony subluxations, or dislocations. In Category 3, ligamentous injury, intramedullary contusions, or SEWARA.
Formulating this diagnostic challenge as a multi-class classification problem is absolute brilliance.
It is. By mathematically separating osseous injuries from ligamentous injuries, the model acknowledges a vital clinical reality. These two pathologies are distinct entities. They frequently result from entirely different mechanisms of injury, they present with different clinical risk factors, and most importantly, they require entirely different diagnostic imaging modalities.
Exactly. A high-resolution CT scan is the gold standard for defining an osseous fracture, but it is notoriously terrible at evaluating ligamentous integrity.
And an MRI is the exact reverse. It is the gold standard for soft tissue and cord evaluation, but less optimal for cortical bone detail.
When the researchers tested this new multinomial regression model against the massive data set, the statistically significant findings were highly impressive. The new model achieved a 1 versus rest area under the curve of 0.903, restoring the predictive power to an excellent level.
And when they compared the new PEDSPINE II model directly head-to-head against the old score for predicting the presence of any injury, PEDSPINE II significantly outperformed it, achieving an AUC of 0.885 compared to the old score's degraded 0.845.
The model learned the nuanced, hidden clinical risk factors associated with CSI in this incredibly difficult nonverbal demographic. When dissecting the data, they found that patients with a confirmed CSI had significantly lower overall GCS scores, and, critically, lower scores on every individual component of the GCS motor, eye, and verbal.
The mechanism of injury was heavily weighted in the regression. Patients with a CSI were significantly more likely to have been involved in a high-kinetic motor vehicle collision, struck by a vehicle as a pedestrian, or be the victims of suspected non-accidental trauma, meaning child abuse.
That finding regarding non-accidental trauma is vital. Severe shaking injuries inherently cause massive whiplash forces that tear the highly elastic pediatric ligaments, leading directly to CORA.
Conversely, the model confirmed that toddlers presenting after a simple low-energy mechanism, like a fall from standing or a fall off a low bed, were exceedingly rarely diagnosed with a CSI.
Let's contextualize this within the broader landscape of pediatric clinical prediction rules. Listeners are undoubtedly familiar with the massive, paradigm-shifting PCARN prediction rules derived by Leonard and colleagues, which dictate head CT utilization, as well as the comprehensive Cochrane database reviews on triage tools authored by Slair and Tavender.
Yeah, those are the gold standards.
How does PEDSPINE II move the diagnostic needle compared to those established guidelines?
The PCARN network has done foundational, monumental work in standardizing pediatric trauma care, specifically in mitigating unnecessary radiation for head and abdominal trauma. Their recent work evaluating cervical spine imaging is excellent. However, much of the prior literature, including the vast majority of the studies analyzed in the Cochrane reviews, has historically focused on binary outcomes. Do we image the neck or do we not image the neck?
The key variance highlighted in PEDSPINE II is that nuanced, multi-class approach.
By discriminating between the probability of a bony injury versus a ligamentous injury, it allows the surgeon to practice highly tailored diagnostic stewardship.
Precisely. Let's look at a clinical example. If a 1-year-old presents to your trauma bay with a highly concerning mechanism for non-accidental trauma, say retinal hemorrhages, and a history of being violently shaken, the multinomial model might analyze the inputs and indicate a low risk for a bony fracture, but a profoundly high risk specifically for a ligamentous injury or SCIORA.
Armed with that specific probability, the clinician can confidently bypass the radiation of a CT scan entirely and opt to move the patient straight to definitive MRI. It is precision medicine applied directly to trauma diagnostics.
But, as the authors clearly and honestly noted in their limitations, this incredibly powerful multinomial regression model is essentially a complex mathematical algorithm running in the background. It is a logistical equation utilizing multiple continuous and categorical variables.
Right. It is not something a trauma surgeon can simply memorize and calculate in their head, while a toddler is screaming in the resuscitation day, the way we could with the old simple 0 to 8-point score.
That is the major unavoidable limitation right now. You cannot compute a multinomial logistic regression on a piece of paper. The authors explicitly stated their ultimate goal is to translate the PEDSPINE II algorithm into a readily available, handheld, application-based bedside tool.
The vision is that you would pull out your smartphone, input the child's exact GCS components, the specific mechanism of injury, and their age, and the app would instantly output the exact mathematical probability of an osseous versus ligamentous injury.
So let me pivot here because we've thrown a ton of complex data at the listener.
Yeah, we have.
Let's do a quick Q&A. I want to play the role of the listener for a second and throw 3 rapid, practical questions at you based on these sources.
Okay, let's do it.
Question 1. I am at a regional center. If my center doesn't have a massive teletrauma budget, I can't afford the fancy video carts. What is the one thing I can implement tomorrow based on the Eldridge paper?
Great question. You focus on the triage guidelines. The Eldridge paper showed that just having a standardized algorithm prevents over-triage. So tomorrow, you draft a 1-page protocol defining which injuries stay and which go, and you set up a simple, direct phone line to your pediatric trauma attending. A simple phone consult backed by a clear protocol will catch a massive portion of these avoidable transfers.
Okay, question 2. Moving to the Anand whole blood study. If the patients needed less volume but mortality was exactly the same, how do I convince my blood bank this is worth the logistical headache of switching from component therapy?
You don't talk about mortality. You talk about morbidity and product conservation. You show them the data that whole blood drastically reduces the total volume of product needed at 4 and 24 hours. You tell them we will use less of your overall supply, and then you point to the significant reduction in ventilator days. Less time on the vent means fewer ICU days, which mitigates dilutional coagulopathy and saves the hospital massive amounts of money and resources.
That's a great angle. Okay, final question. With PEDSPINE II, if the old score's AUC dropped to 0.81, is it officially obsolete? Like, do I just throw it away?
Absolutely not. The clinical criteria are not obsolete. Their mathematical sensitivity has simply been diluted by modern, hypersensitive MRI practices. You should not wipe the core clinical variables from your brain. A GCS less than 14, an abnormal eye-opening response, involvement in a motor vehicle crash, and age, those exact same variables were proven by the new multinomial model to remain the fundamental pillars of risk assessment. What is obsolete is the blind dogmatic confidence that a simple score of 0 equates to a 100% ironclad guarantee of no injury in the era of 3 Tesla MRI.
Excellent. Okay, let's bring this all together. We have covered a massive amount of ground today, navigating the entire continuum of pediatric trauma care through the lens of 3 paradigm-shifting studies. Here is your rapid-fire synthesis, the core clinical pearls you need to integrate into your practice tomorrow. Number 1, regarding access and triage. The Eldridge teletrauma data proves that geography is no longer an excuse for secondary overtriage. Utilize high-definition teletrauma networks backed by strict daily virtual rounding to keep safe, stable pediatric patients in their local communities. You must protect your level 1 resources, your beds and your ORs, for the patients who truly require complex operative intervention.
Number 2, regarding hemostatic resuscitation. Aggressively advocate for the integration of low-titer whole blood in your pediatric massive transfusion protocols. The Anand propensity match data is clear. Component therapy induces dilutional coagulopathy and massive citrate toxicity. Whole blood provides superior, balanced hemostatic resuscitation, significantly reduces total transfusion volume, and cuts down on prolonged ventilator days and ICU morbidity.
And number 3, regarding diagnostic stewardship. The Luckhurst PEDSPINE II study exposes the dangers of modern verification bias. We are overscanning toddlers. Trust the robust clinical prediction variables, GCS, mechanism, and age to guide your suspicion. Recognize that osseous and ligamentous injuries are distinct entities requiring tailored imaging, and aggressively fight back against reflex pan scanning to protect the child from unnecessary radiation and sedation.
If we synthesize the overarching theme of these 3 studies, it profoundly illustrates that the definition of a master surgeon has evolved. Surgical critical care is no longer defined solely by your technical prowess in the operating theater or how fast you can pack a liver. Being an expert today requires system-level stewardship. It means acting as a fierce steward of your regional trauma network's physical beds, a steward of the community's incredibly finite blood bank supply, and a steward of diagnostic radiation. Your impact extends far beyond the sterile field.
The evidence we unpack today empowers you to make those high-level decisions, ensuring that when the truly critical, dying patient arrives at your doors, you have the exact physiological, physical, and diagnostic resources necessary to save their life. So, we will leave you with a final, forward-looking, thought-something to mull over as you drive to your next shift, building on the convergence of all 3 concepts we've discussed. We have seen the incredible power of teletrauma video feeds connecting rural outposts to centralized supercomputers. We have seen complex algorithmic propensity matching isolate the exact physiologic benefits of whole blood resuscitation. And we have seen advanced multinomial logistic regression models analyze vast data sets to accurately predict the probability of subtle ligamentous cervical spine injuries.
It's incredible how fast this is all moving.
It is. What happens when these 3 disparate data streams fully converge? Imagine a near future where an artificial intelligence model continuously analyzes the live, high-definition teletrauma video feed from a rural emergency department. The AI automatically tracks the child's breathing pattern, analyzes their spontaneous movement to calculate an immediate GCS, and processes the EMS report regarding the mechanism of injury.
Oh, wow.
Based on that real-time analysis, the algorithm automatically triggers the whole blood massive transfusion protocol at your level 1 center before the helicopter even lands on your roof, while simultaneously running a continuous multinomial regression to calculate the exact probability of a high cervical ligamentous injury, allowing you to bypass the CT scanner entirely and move the child straight to the OR or the MRI suite.
That is the ultimate frontier of trauma surgery. The individual technologies, the synchronous telemedicine, the whole blood protocols, the predictive mathematical algorithms are already here. They are published, they are proven, and they are functioning in silos.
The only question is, are our trauma systems culturally and logistically ready to integrate them?
And navigating that frontier requires an absolute mastery of the data.
Keep questioning the dogma, keep pushing the boundaries of your practice, and we will see you next time on The Deep Dive.